I want to talk about a topic that Ann and Ruben gave me that is a passion to me and to many of you, but the word is future. So in contrast to what Ruben and Mike just laid out to us, that's the current. That's what we're doing right now, and I loved your questions here as I listened. I want to try to put this in more of the future tense because my goodness, we're working on these, but most of these that I'm going to show you are not yet FDA approved. So let's keep that in our mind. So as we do MPN combinations in the future, as you just heard from the previous speakers, the landscape, the excitement is there for all of you, for patients, caregivers, and the rest of the people in the field. Take a look at this list. I tried to just start keeping track during the pandemic around 2021 of what was going on. In the polycythemia vera space, we've had zero research for almost 30 years in the clinical trials. Now we have ROPEG interferon, some of you know it as Bezremi, which was approved in 2021. Really the first and only, in my experience, that was done all in Europe for a long follow-up, and then FDA approved by us, and we're prescribing it here in the clinic. Pretty amazing. Dr. Kirkendall and others, including myself, are working on the rusfertide, which is also known as PTG 300, the hepcidin mimetic, which is now completed. It's completed its phase 3 trial, so we're waiting for that. So that's in polycythemia vera, other trials on the way. Essential thrombocytosis, as we heard from Ruben, even there we have some developments with the Bezremi and the Bomenemstat, the LSD1 inhibitor in late-stage clinical trials. The rare diseases, the ultra-rare diseases, as Mike and Ruben mentioned, I love that we have FDA-approved trials now, so putting not only a name and a face to it, but actually it usually creates a field. You get more drug companies involved, more stakeholders, and that's what we're seeing with systemic mastocytosis and the KIT inhibitors. The most ultra-rare of ultra-rare, if any of you have the 8p11 syndrome, we got this drug approved led by Serge Rostovsek, less than 30 patients, because this is such a rare disease. And so pathologists and doctors need to look for it. Now, the focus of my talk is to look for these combinations. Outside of our 4 JAK inhibitors that you know, ruxolitinib, fedratinib, pacritinib, momelotinib, now we're starting to see, can we combine? Can we do JAK inhibitor plus something else? But team, we owe you a few things. If we're going to do that, it's got to be safe. Well, it's going to add new toxicity, isn't it? So it has to be justified medically, scientifically, and financially as well. What the heck are we doing? We're trying to make you live longer, feel better. Well, these combinations haven't yet shown that, so we need to get there. The 4 I'm going to highlight are the ones that have made it to what we call phase 3. So remember, phase 1, earliest clinical trials, sometimes often first in human. Phase 2, now confirming the safety signal, maybe trying to get efficacy. Phase 3, the larger clinical trials. And then actually from there you can get FDA approval. There is something called phase 4, which is usually post-marketing or larger follow-up studies. And then we'll talk about some of the anemia trials if we have a moment. The reason why we're meeting today is despite all of the success of the JAK inhibitors that many of you in this room are on, I'm sorry to say that we haven't cured the disease by itself. So as the question was asked earlier to Ruben, can we cure the myelofibrosis? Yes, but that's with allo stem cell transplant, as Dr. Grunwald showed us. Without the transplant, and I want to be very clear, allo transplant is the only curative modality. Without that, we can have good hopes and nice aims to put the disease into a long-term check, control, and sometimes that can be for decades, and that's a win for all of us. But as our colleague Dr. Palandri showed in Italy, 218 patient retrospective, so she looked back in her charts in Italy, a large amount of our patients. Shockingly, she found that at 3 years, almost half of the patients stopped taking their Ruxo. One of you had mentioned about 3 years. Yes, we all have patients, many of you here, that have been on longer. But there's always something that's going on around the 3 to 4 year mark. A lot of times it's not a good reason, right? Adverse events, transformation of the disease, et cetera. Some people coming off for a good reason to go to transplant. But the supposition is, as much as I personally and all of us are excited about JAK inhibitors, we're not curing the disease. So we need to do something else. That's my hypothesis. The question is, what is that something else? In their analysis, they found that the use of investigational agents here at the bottom right, clinical trials, new drugs, what we're going to be talking about, could be the answer. Well, the problem with that is that we have new toxicities that we're introducing as we ask you to enroll in these clinical trials. What's the point of that? What are we trying to do? Well, our hypothesis is that if we intervene in the disease earlier, maybe even at the front line. So when you're first diagnosed with your PV, your ET, or myelofibrosis, prefibrotic MF, maybe, just maybe, we can intervene and we can lead to greater outcomes for you. Said in another way, maybe get to the disease before it's too late, before there's too much clonal burden, before there's too much problems with it. And so we're calling that early disease modification. With that theory and approach, now we've asked patients to enter into clinical trials where we add in the second drug, not later on, not second, third, fourth line, but front line. This is just a list of them. The list is growing. I tried to highlight the ones that are in the phase 3. The four that I would highlight are the Rux plus Pelabresib. That's a bromodomain or BET inhibitor. We'll chat about it. Rux plus Navitoclax, BCLXL. Rux plus MDM2 inhibitor, navtemadlin. Rux plus selinexor, XPO1. It gets into alphabet soup quickly, as you all know, but I think the concepts are a good one. Combination of JAK inhibitor plus some new drug that's not yet approved. What's old is new again. At our center, led by my colleagues, Dr. Lucia Masarova, Dr. Daver, we actually took one of the older drugs that some of you know, azacitidine. That's FDA approved in AMS and MDS and AML. And it's been used in the later stage of the disease, but we asked the question, can it be given earlier on? And the answer is yes. So with the Ruxo that you're familiar with, we gave the azacitidine. More toxicity though. It's an IV or a sub-Q drug, and we were able to show improved outcomes, 72% overall response rate, 71% of spleen shrinking. To give you some baseline, the ruxolitinib is about 40% in the original studies led by Rubin, Claire Harrison, and Serge. The problem is that there's increased toxicities. You can have counts dropping, so a little bit higher chance of infection. That's not good. A little bit higher chance that the blood counts may not recover. And ultimately, what are you doing with this combination? Are you trying to get people to transplant, et cetera? So that's what happened on this study. We were able to show that it was feasible, safe, larger spleen size reduction, but more toxicity. Now we move into the modern era. This is all hot off the press just this year. This is the most exciting combination for our field right now. This is the Pelabresib, which is a bromodomain or BET inhibitor. All of these are pathways in the cells, not yet approved. But our colleagues, Rajit Rumpel and John Mascarenhas in New York, showed in a global randomized phase 3 study that they can give patients the Ruxo and the Pelabresib combination, frontline. You'd never been treated before. And the control group is actually ruxolitinib. So the control group is what you would already get anyway. That's a good trial. That means that you're getting the standard as a minimum. You're getting the new thing as the other choice. So what they showed in this Manifest-2 trial is that it's a huge trial for our field. It's actually the second largest trial, 430 patients, just shy of one of the simplified trials, which had 432 patients. So a huge number of patients all over the world, primarily done during the COVID pandemic. They showed that in these intermediate high-risk patients, importantly, they included intermediate 1. So some of you may be intermediate 1, generally not included in most of these trials. Randomized, as I told you, Pelabresib plus the Rux versus Rux alone, and then the usual endpoints, guys, right? So spleen reduction, symptom improvement by week 24. This study was a positive study. The primary endpoint was met. This is called a waterfall plot where each patient is a bar, so you can kind of see it in aggregate quickly and visually. What you should get out of this chart, this graph, is that 66% of patients who got the combination, that's 214 patients, by the way, had this SVR response versus only 35% in the Ruxo plus placebo. So doubling the control group. And again, the expectation, right, from the COMFORT trials was around 40%. That's a positive study. The p-value is the mathematical thing that tells you that this was positive. However, what you also care about, we care about, you care about, is the symptoms. And the symptom burden, we added that second drug, didn't we, team? We added a second drug with its own attendant toxicities. Oh, it just didn't quite make it. Look at this p-value, 0.0545. You're supposed to be less than 0.05, so it just missed that. Again, if you look at the visual aggregate here, a lot of patients had benefit. So the absolute change just missed the statistical significance. So because of that, the status is unknown. We await, I await, we await what's going to happen with this drug. Does it get approved or not? When they did a little bit deeper analysis, they found that there was quite a few patients who had both spleen and symptom response. This Venn diagram is the first time we've seen this in the field. I think it's a good one, just to show that the confluence of people who had the benefit of the two major for primary and secondary endpoint was quite a few patients that it tracked together. And I didn't show you the toxicities here on this slide, but it's a fairly well-tolerated drug. Some patients did have some low-grade GI. Some patients had some taste changes, but other than that, the blood counts came out okay. So this is promising, but let's all keep track. I hope we find out by the end of the year. The second combination is that of Navitoclax. This targets another pathway called BCL-XL, and I had the honor of leading this trial. Same kind of concept that in the lab, this is a new pathway beyond JAK-STAT that shows that if you can halt it, stop it, take care of it, that maybe either by itself or with JAK inhibitor, you can do good for your patients. That's what it says in the lab. Let's see what happened over the last 7 years of our effort. In the earlier stages, phase 1 and 2, just a small number of patients, this was led by myself and Professor Claire Harrison from UK, what we found in 32 patients is that if you're still on your ruxolitinib, but it's not quite working out, we call it suboptimal failure. So you're not quite failing the drug to come off, it's not quite doing what you want it to do. Can you keep on the Jakafi, the ruxolitinib, and then add in the new drug? This is a new field. This is called the add-on field. And in that small group of patients, 32 patients, it's a small niche of you, right? You have to fit into that category. It took us some time to enroll. What we found was 3 things: that the combination was fairly safe, although unlike the Pelabresib, the blood counts do drop a little bit more. So you could get neutropenic, anemic, thrombocytopenic in a lot of the patients. But it was safe. 2, we found that, yes, we shrank the spleens even in those patients who were starting to look like they had to come off. And then finally, overall survival. Unfortunately, if you have myelofibrosis as a chronic disease, it can become an acute, life-threatening disease to you if it's starting to progress past the front line, right? So clonal evolution, the drugs are not working. So this just shows you that at the median follow-up, we didn't have, the median overall survival was not yet reached, which means patients were doing quite well at 2 years. So this is the initial data, generated some excitement. We published it in a major journal. My team and I looked further to see who were the patients who were best responding to this combination, and it turns out for the first time we started to see markers of early disease modification. If you look here, basically what we're trying to explain here is that the folks who had the most overall survival, small group of patients, were the ones who had a decrease in either their allele burden, variant allele burden, the number percentage, if you will, of your JAK2 or CALR, and then the people who had bone marrow fibrosis reduction. Small number of patients, can't hang your hat on it, can't change the whole field, but the concept is maybe the drug is doing what we're hoping it could do. So we took this into phase 3 trial, and I'm going to show you another positive trial here. So this is called Transform 1. I presented this at the EHA meeting in Europe a month ago. Again, phase 3 randomized, just like I showed you for the other one. The investigational arm is the Rux plus the Navitoclax versus ruxolitinib placebo. So again, if you're in the control group, you still get Rux as the baseline, which is what you were going to get anyway. When we look at the patients, the vast majority of them are intermediate 2, so 80%. Half of the patients had high molecular risk mutations. Maybe we'll talk about that, ASXL1 and other mutations outside of your JAK-STAT pathway. But the point is 252 patients, high-risk patients. This is the take-home slide. Again, just like I showed you with Pelabresib, 63.2% at SVR 35 at week 24. So a nice, good number of patients versus only 32% in the ruxolitinib arm. So again, doubling, really doubling and highly statistically significant. But just like I showed you, what happened to the symptoms? The symptoms did not hit either. So they were not statistically significantly better in the combination than the Rux. Now, talking about this with you guys here in August as compared to 5 years ago, it kind of makes sense, right? How are we going to improve on Rux as a single agent with the combination and make your symptoms better? That's a tough bar, it turns out. So both of these trials did not quite hit that. So we'll have to see what the fate is. This particular program, the Navitoclax, won't be continuing on, whereas the Pelabresib is still in the active consideration. So that's the Navitoclax. The third one to highlight to you is that of the selinexor. This is a novel drug. Actually, it's approved in multiple myeloma lymphoma, so it's not a brand new drug, but it hits this pathway called XPO1. Small number of patients showed the highest spleen volume response rate that we've seen, 90+%. That was the first 14 patients. So that's the excitement's there, and so now that's going into combination with the Ruxo, just like you saw the other two. So again, a phase 3 global trial, randomized, Rux and the selinexor, the new drug. 60 weekly, so just one dose Q weekly. Why is that? That's because in the other drug development stories, there was a lot of nausea, vomiting. So that's something I do worry about for this drug. But the trial takes care of that. It mandates that people have to be on antiemetic therapy to start, and then you're watched closely for that. Also, the dose is reduced significantly from the prior experience. So what does this tell you? This means there's a third trial now that's active. It's enrolling at many of our centers. Frontline patients who've never been treated. A fourth drug is called Navitoclax. This is an MDM2 inhibitor, also entering into a phase 3 trial. 600 patient trial plan called Poesis, where everybody starts out on Rux, okay, and then you're followed to see if you have a suboptimal response or not, and then you're added into the new drug, the Navitoclax. So a very novel study that's open at many of our sites. John Mascarenhas in New York is leading an imetelstat add-on study. We hope to see the first data of that at the ASH meeting. And here you have a new drug that's a telomerase inhibitor. Telomeres are these caps at the end of your chromosomes that you may have heard about with aging and cancer and disease. This is a first-in-class drug. I'm actually eagerly excited to see what happens there. As a single agent, it's in phase 3 trials to see if it can get approved in the relapse refractory setting. And then there's even more drugs. I don't want to take up too much of your time, but I want you to have hope, and I want you to know what's going on. And these things are exciting. They're new. And darn it, they're new in the whole field of oncology and hematology. We used to borrow from the other fields. Now we're innovating on our own. This is cord blood cells that are being developed at MD Anderson by my own colleagues in-house, which are unmatched and which can go exactly to the immune system directly. And so this is being tested in aplastic anemia patients, myelofibrosis, MPN, et cetera. And this is being led by Dr. Lucia Masarova, and this is currently enrolling with ruxolitinib. And then finally, I mentioned the anemia combination strategies. For many of you, anemia is an issue, right? And blood transfusions, okay, that's fine, but can we do something besides growth factor shots and blood transfusions? The Incyte company has nicely developed a trial which includes a new agent called zilurgistrib. So the ZIL drug aims to hit this ACVR1 ALK pathway, which is implicated in anemia and hepcidin. Elritercept is another new drug that's again being combined with Rux to try to help anemia. So team, in closing, what I want you to get out of this is that there's a lot of clinical trials going on, not to overwhelm, but to provide hope. To know that you can go to clinicaltrials.gov. That's a government-owned, US-owned. It's a free website. Anyone can go. It's actually regularly updated. You can check in weekly, monthly to see, and you can go by, you can type in Pemmaraju, you can type in Kurkendall, you can type in myelofibrosis. These drugs, this article I think we wrote, Anne, a year or two ago, we have to add quite a few things to this. So inside and outside the cell. I think what we have to do as a field together is we owe you more, which is we've got to get drugs that not only shrink the spleen and symptoms, that's important, as Ruben and others have shown, but let's try to improve your overall survival. Let's try to prevent you from going to accelerated blast phase AML. Let's try to bring down the burden of the disease in a biological way that makes sense that we can show you in the clinic. So we talk about variant allele fraction, allele burden, but it doesn't often correlate with the treatments we're giving, unlike, say, CML or other cancers where it nicely comes down. So we owe you that. And then with our scientists, Dr. Angela Fleischman is here and others, are there new biomarkers that we can discover together, patients, doctors, scientists, that can then inform us for the next 10 clinical trials? And that's another reason why it's important, if you have the ability, the chance, the opportunity to enroll in a clinical trial. And so, Anne, I would just conclude by saying that there's so many new directions for combinations. I just showed the latest stage 1, so JAK inhibitor plus something else, anemia combination improvements. We didn't have time to go over the immune-directed therapies, which are super exciting to many of you. And then could we have a space for novel combinations? So that's where we take bromodomain and BCLXL, leaving out the JAK pathway in the later stages. So, Anne, with that, I'd like to close and happy to take any questions.
Thank you so much. That was great. So we have time for just a few questions, but let me reiterate that you can jot your questions down for later today when you're actually sitting with some of these wonderful speakers. But go ahead. We'll take a few right now.
A couple of quick questions. Why did you choose Jakafi only to do the combination studies? And secondly, why not more combination studies like using hydroxyurea and OJAR or hydroxyurea? Can you explain
Awesome
why
question.
that was chosen and why you didn't use like Ojara, for
Yeah.
instance.
So awesome question. First of all, you're 100% right. That's where the field is headed. So you're ahead of the field, which I love. It's interesting that all these combinations, without even saying it out loud, you nicely picked up, they're all ruxolitinib base. It's what you think. The answer is because that's first in field, probably best in class, longest experience. So that's where the trials happen to go. You also have, in addition, a long-term toxicity profile that we know about. So there were older combinations that I didn't show you with Rux, so we have some track record of safety, and we know what's going to happen with that drug. The newer drugs, as you mentioned Ojara, which is momelotinib. Those are pretty new. I mean, those have only been around for a few years, at least in the FDA approval. Obviously, we've had them in trials longer. So as you anticipated, at this moment, those trials are being written. Selinexor, for example, has already announced that they're doing a trial where they will do exactly what you said. They'll allow the combination of any of the JAK inhibitors, momelotinib, pacritinib, et cetera. And then, as you say, frontline trials are being designed to do, fedratinib plus whatever, pacritinib plus whatever. The second part of your question is a great one, Hydrea. I liked Ruben's comments earlier. If you come to my clinic, we do prescribe Hydrea, but we try to see if there's the other drugs that we can do. The concept is we think that Hydrea may possibly have the least disease-modifying effect compared to some of these more modern. Hydrea still has a place in the patient with the high white count, ET/PV, if you can't give interferon due to real contraindications. So you won't see Hydrea matched up as often anymore because we're moving beyond that in a good way, I would say, for our field.
Any other questions for the moment, or do you have a question? Yes, okay.
You just spoke about the interferon drugs, but
Yes.
how come there are no clinical trials involving, I mean, that's an old drug that's been around for a long time. Do you see a lot of success with the interferon?
Yes. I'm really happy you asked about it. Darn it, I cut that slide out. So they told me I needed to stay on time. You're so right. So I'm a huge fan of interferon. I should have mentioned that. Dr. Lindsay Rain, my colleague, is here, who also is as well. Dr. Silver in New York, who many of you know, our beloved dean of MPN. Two things I would say. I love what you said. So what's old is new again, right? I said that with the hypomethylator azacitidine, but you're right. You'll be happy to know that there are multiple trials ongoing with combination of interferon, and I should have mentioned that. One that I'm really excited about is called the RuxoPEG study. So exactly what you're seeing, ruxolitinib plus interferon. So you two are sitting next to each other. So yeah, there you go. So that's the combination right there. You two represent the combination. So that's cool because you know what? People maligned him for doing that study. They said, oh, you're going to have too much toxicity in the patients, too much overlapping toxicity. Well, they didn't. What they did is they dosed each nicely. They did it in a Bayesian design where they really looked at safety, each 1 to 3 patients. And actually they found the reverse, that it was well tolerated and they're seeing greater efficacy. There's also efforts to try to combine with the newer one, the RoPEG, that's called Besremi, either with JAK inhibitor or other agents. And then, as you said earlier, sir, can you combine these with the momelotinib, pacritinib, fedratinib for sure? So let's not forget about it. But the toxicity profile is there. As you combine it with other drugs, you need to watch autoimmune, liver, all the things you already know. So you should be heartwarmed to know that those trials are going on, and I'm a big fan of them.